you guys all know how much I hate GI bleeders. A couple years ago, I had bad cases, a couple bad outcomes. They tried to fire me, and my punishment was writing this lecture. Believe it or not, that's all true. So we're talking about GI bleeding today. We're talking about all different causes, the things we're going to concentrate on. Different causes of GI bleeding. I'm going to do a lot on varices. A lot of this will overlap with what Steve said. I appreciate him putting in that work for me, so it explains all my stuff. Physiology, how you make the diagnosis, and then some treatment on top of it. So these are all different causes of upper GI bleeding: Mallory White's hair, esophagitis, GERD. Peptic ulcer disease is probably the most common one we see. And of course, AV malformations, cancer, foreign bodies, trauma. And then lastly is varices, which is the worst one we see, and it's the one that I fear the most. Because remember, GI bleeding, you can't compress it. Any other bleeding, you can compress it and stop it. But GI bleeding and maybe penetrating neck injuries, you just can't stop the bleeding. It continues and continues and continues until something bad happens. So Mallory White's hair, it counts for less than 10% of bleeds, and it's usually caused by vomiting or retching. If you guys have ever seen them do an endoscopy, when the person retches, when you have the scope in there, you can see the whole stomach just involute and turn over. And you can picture how that'll stretch out the lining because the stomach is now inside out, and it just gets tears in it. Usually they're mild, it's self-limited, it's not that big a deal. The classic case is somebody with hyperemesis, or habeas corpus, or GI infections, alcoholics. People just keep vomiting again and again and again and again, and they constantly stretch their stomach and just rip the lining. But again, it's self-limited, not much happens with it. Treatment, just stop the vomiting. Give them antiemetics and calm their stomach down. And then let them have a little stomach rest. Right? Give them some IV fluids for 6 hours, 12 hours, maybe put them on OBS. But if you can stop the vomiting and make their stomach better, then usually the bleeding will stop because it reheals itself. Remember, your GI tract has a very high turnover and a very high repair rate. So gastritis we see a lot, but it's not as benign as you guys think. Remember that with gastritis, you don't penetrate the mucosa. It's only erosions of the mucosa. Everybody says it's benign, but again, 6% require surgery, 8% mortality rate. The mortality rate is probably not due to the gastritis itself. The mortality rate is probably due to the bad protoplasm of the person with gastritis. A lot of times these guys are drinkers and have other underlying pathology. It can be infectious. Drugs like NSAIDs will definitely lead to bad gastritis. And then obviously the one we see all the time is alcohol. So treatment, again, remove the offending trigger. Get them to stop drinking, get them into rehab, have them stop taking Motrin 5 times a day. Get them some GI reps, right? Get them IV fluid for a day, put them on OBS, don't let them eat anything, and then get them a better diet. If they're only consuming alcohol, getting them a nice healthy diet will try to let their stomach repair itself a little bit. Decrease the amount of acid in their stomach with either H2 blockade or PPIs will definitely help too. And then give them some Maalox, something that will neutralize the acid, coat the stomach, allow your stomach to fix itself. Gastritis can also be infectious or gastroenteritis. You know, we have those 5 or 7 bloody diarrhea bugs that you're supposed to memorize and know for your in-service. Salmonella, Shigella, E. coli, Campylobacter, Yersinia, and then the other bad ones like C. diff, histolytica. And I thought this was interesting, I didn't know this, that Klebsiella can do it in people who are being treated chronically with antibiotics. You also have your non-bacterial causes of diarrhea. The norovirus and norovirus is a very common one. This is the one you see on cruise ships all the time where like 90% of the cruise ship gets sick. Not a fun cruise to be on when everybody's going to the bathroom all the time. Usually it only lasts 12 to 60 hours. But remember, 12 hours or even 60 hours with 2 bouts of diarrhea every hour is not a very fun moment. You got to keep up with your hydration status. Everything that comes out, you have to replace and put back in. And there's no antivirals for it. For some reason, they found that people with type O blood types were more susceptible, but excuse me, nobody knows why. I'm not sure. I couldn't find anything on it. I looked into it. I just didn't see anything. And then Cryptosporia and Cyclospora are very, very common causes of non-bacterial diarrhea.
Immunocompetent people? Cryptosporia?
People who are on steroids and people who have HIV or people who are transplanted, those guys usually. Treatment, if it's one of the 5 gram negatives, you want to give them gram negative coverage, right? Fluoroquinolones, 3 to 5 days. Some of the fluoroquinolones are expensive, maybe they won't be able to afford it, so you can use Bactrim. Although Bactrim, in my opinion, is a horrible drug. So many side effects, so many weird things happen with it, and then there's a lot of resistance in certain areas to Bactrim. So if you can get them to fluoroquinolone, you're probably better off. If they've been on antibiotics recently, then you have to suspect C. diff. And for you guys who have seen it, C. diff has that very characteristic smell that you can definitely figure out what they have. Give those guys metronidazole or PO vancomycin. For children with bloody diarrhea, you definitely don't want to treat them because when you give them treatment, they end up developing hemolytic uremic syndrome. Peptic ulcer disease we see a ton of. It's an erosion through the mucosal layer, down into the submucosa and into the muscular layer. If you're unlucky, they'll get even through there and they'll perforate. You have five times a chance of having PUD if you're over the age of 50. So all these older patients we see have a much higher chance of having it. Some of these people have just painless ulcers, and these are the guys that usually present with symptomatic anemia, but you don't know why. And usually it's due to painless peptic ulcer disease. Drugs like aspirin and other NSAIDs are a leading cause of this in people who aren't drinkers, and you want to just protect their stomach. You want to stop them from producing all that acid. So stress management helps if you can get it for them. And then people with Zollinger-Ellison syndrome is a really uncommon cause, but people who develop ulcers again and again and again or have multiple ulcers, a lot of them, you might want to think about that. And then H. pylori is an infection that really leads to a lot of our causes of PUD. All right, here's a chest X-ray for you guys to look at. What do you guys see?
Yeah.
Good. Free air in the diaphragm jumps out at you, right? But don't get caught by satisfaction in the search. Notice the free air in the mediastinum too. Remember that when you have the ulcer, it's right underneath the diaphragm, right by the diaphragm cruce. So the air can jump up between the rent in the diaphragm up into the mediastinum as well. So symptoms, usually it's upper abdominal pain, burning in nature. It goes from their belly up into their chest. But again, it can be painless. So these are the guys that will present with a symptomatic anemia. If their bleeding is very heavy, then you'll have much more symptoms. All right? Hematemesis, vomiting blood, hematochezia, blood from below. And if their transit time is slower, they have more time to digest the blood, you're going to get that classic melena kind of picture, where the blood is very dark black, it looks like tar, and it has that horrendous smell to it. H. pylori, we'll talk about that a little bit. It's a gram-negative microaerophilic bacterium that lives in the gastric mucosa and the mucus. H. pylori is an interesting bug. It has this urease. All right, urease is an enzyme that'll break down urea into carbon dioxide and ammonia. So if you give somebody urea that has carbon-14 in it, or radioactive carbon, you can actually test their CO2 coming out. And if their C14 is in the CO2, then you know they're splitting urea. You know they have urease in their belly, and you know they're splitting the urea. That's how you test for it. You can also do blood antibody testing, stool antigens, ELISA. Biopsy is the gold standard. But why would you ever want to biopsy somebody and put a camera down their stomach when you can just do the urease test? Doesn't really make sense to me, but you know, GI guys got to pay their car payments, so they still do it.
That's over?
Yep.
Oh, well, I don't know, but can we treat H. pylori from the ED?
We can. I'll talk about it in a slide or two. So treatment, you know, PPIs to get their stomach calmed down a little bit, H2 blockade, also to stop the acid production. Antacids will help because it'll neutralize the acid that's already there, not even stopping the production. And then coating agents like sucralfate and stuff like that. Again, like you were just asking about, treatment is triple therapy, which we're going to talk about in a second. Believe it or not, smoking cessation is very important. People who smoke a lot end up having much more ulcers and much worse peptic ulcer disease. And then your diet is important, right? What you eat, if you eat healthy, your stomach will recover much quicker. Over. Triple therapy, this is what you're asking about, is omeprazole, amox, and Clarithra, plus or minus bismuth. So what this will do is this will get rid of the H. pylori and give your stomach a better chance of healing. People who are penicillin allergic, you want to give them Metro. And then there's a couple other causes of GI bleeding that are not so common. All right, esophagitis, when you have a really bad regurg, you can burn your esophagus. You can end up with Paget's. AV malformations, and here's a case of gastric cancer with this fungating lesion. These all can bleed. And then foreign bodies and trauma. You can get a lot of things in your belly or trauma to your belly that can definitely cause GI bleeding. So I wanted to test you guys on your recognition of foreign bodies. So here's a couple that I've seen. All right, who recognizes that one? Good, that's their dentures or a bridge. This is really important when you guys go to incubate people. Make sure you pull these out so this doesn't happen. That's how this point got there. What do you guys see? Good, huge staples. These are the staples used to hold your carpet down. Probably shouldn't be eating them. AP and lateral from a kid. This is actually mom's earring. Kid was up on the kid, mom's shoulder and just ate the earring off her ear. Not Mike Tyson's kid though. This one's got to be taken out, right? Anything that's sharp will not navigate the GI system without perforating it. All right, another one with a needle. At least this person used safety pins, not sharp pins. They're pretty safe. Cheap metal screws. No, this guy, oh, this might not be the right one. This is a kid. There's a guy that comes in like probably 3 or 4 times a month after eating things now. He just likes being in the hospital. He likes getting endoscopies.
Didn't he come back in like 24 hours? They did an endoscopy on him and he came back that day.
Yeah, I saw him the second time. He was discharged for only like 8 hours and came back with a knife, a serrated steak knife in his belly.
They were so pissed.
So this one probably is not an upper GI foreign body. This one's probably lower. 1 in a million chance for that Phillips head screwdriver to get in there. So this one is actually you'll see quite often. This one's a straight razor. A lot of prisoners will do this. What we'll do is they'll take a razor blade and put tape around it and then swallow it and then complain of belly pain. When you x-ray it, they look like this. It looks like a razor and everybody's worried they're going to perf their GI tract. And it gives them a little trip out of prison to go sightseeing and see a hospital and be outside prison for a little while.
I saw somebody do it, they froze it in an ice tray. They worked in the kitchen in the prison, and it's those little razor tops in an ice tray and swallowed a cube of ice.
So I would not recommend you do that because the tape it stays on and it goes through your GI tract with the tape. Once the ice melts, you're kind of exposed to the sharp side. I don't recommend you do that.
Now you have a rusty razor.
Yeah, but it's rusty. So I don't really recommend you doing that one. Button battery, remember, always look for that double ring sign. Button batteries are much worse than coins. Button batteries are not constructed well. They open up quite a bit. So this one's a little harder. So everybody thinks it's the clips from the cholecystectomy, but it's actually organic matter. Probably not an upper GI foreign body. If it is, that's pretty impressive motility.
Really increasing fiber.
Yeah. That one was kind of big. I don't get it, Maurice. What's wrong? This one was impressive. Your toothbrush with the travel case. Along the same lines, electric toothbrush vibrates a lot.
Yeah.
People do crazy things, man. It's job security. This one was actually an interesting case. This was in Fast Track about 3 years ago. The guy came in, he was Spanish speaking only. He was seen by an English speaking doctor, complained of belly pain. The doctor said there's nothing wrong with you, go home. He came back the next day, saw a Spanish speaking doctor, and said he tripped over the garden hose and he had a sprinkler in his butt. It's all in the history. Make sure you get a good history. If you have to get it translated, get it translated. Spray paint. This is the famous one. Really amazes me how simple these objects are. It's just a weight on a motor, and the weight is off center. When the motor spins, it vibrates. All right. So let's move on to the second half of the talk. Let's talk about varices. This is the one that I fear the most. I think this is the one that most people die of. All right, people with cirrhosis, usually due to hepatitis or alcohol, you end up getting portal hypertension due to damage of the liver. And we'll talk a lot about why that happens. If you see a person who has cirrhosis and is altered, you should automatically suspect a GI bleed, right? When you get altered, it's usually because you have a lot of protein in your system, and you deaminate that protein, you deaminate the amino acids. But where does that protein come from? Well, if you start bleeding in your gut, there's a lot of protein there. The globin part of hemoglobin is all protein. So anytime you see somebody's altered, think about GI bleeds, right? 60 to 70% of these guys re-bleed over and over and over again. 30% will require surgery, and then a third of GI bleeds will die. So 1 in 3 is not going to have a great outcome. Causes of cirrhosis, I think Steve touched on a lot of this stuff. Hepatitis B and C. Alcohol is one of the big ones that we see, but then there's all these other like less common ones, such as psoriasis, Wilson's, hemochromatosis, TB, and then Budd-Chiari syndrome. So Budd-Chiari syndrome, like Steve said, is hepatic vein thrombosis. You could have portal vein thrombosis as well. In 50% of people, nobody knows why it happens, but it just kind of does. But people with protein C, protein S deficiencies, who are prone to clotting get it. People with malaria get it because you have such a high load of cells in your liver that break down, get stuck there. They get the clotting also. And it gives you a lot of ascites, especially in little children. So how does cirrhosis happen? What happens? What causes the problems? Well, as your liver dies off, you get loss of endothelin-1, which is an enzyme that helps make you nitric oxide. If you guys remember, nitric oxide is a vasodilator. So without your nitric oxide, all the caliber of the sinusoids in the liver gets smaller. As your sinusoids get smaller, pressure goes up. On top of that, you get deposition of protein, deposition of fibrin in the space of this, which also makes the sinusoids smaller, and you get sludging and less flow. As you get less flow, pressures go up, and then you start to get your problems. All right? The more pressure you have in the liver, the more chance you have of straining out fluid, and the more backup you have into the portal system. As the portal system backs up, it'll drain over into the systemic system as well. So when you have cirrhosis, you get liver destruction, and then you have obstructed flow within the liver. Right? You start to develop your collaterals. This is where you get the problems. As your collaterals get bigger and bigger and bigger, they have a bigger chance of rupturing as well. You also get loss of function. So not only will you rupture the collaterals, but you won't clot them off because you have less proteins for coagulation. Additionally, you get encephalopathy, so you don't really think very well, you don't do things that are great for your liver, and your child's classification goes up, which has a higher chance of mortality associated with it. So I put this up there just so you guys see where the collaterals form. Again, your portal circulation is everything off your large and small intestines. So the places where it meets the systemic circulation are in the esophagus, that's where you get your varices. Down at the rectum, that's where you get large vessels there too. And then umbilicus, you get your caput medusa. Right, so those are the 3 places where your portal circulation meets your regular circulation. So we talked a little bit about different classifications. Your child score is just to predict how badly you will do. All right? They took out a lot of things, put new things in. It's changed over the years. It has a decent predictive value, if you can see here. They look at a bunch of different things that have to do with your liver function. Bilirubin, albumin, INR, ascites, and encephalopathy. And they give you different amounts of points. And you can see if you're only a class A, you have a decent life expectancy, 15 to 20 years. But if you can get up to class B, you're a candidate, and now you have a 30% mortality. And if you get up into class C, you're really not doing very well. So it's really important not to let these progress as much as you possibly can. So how do you make the diagnosis? Well, endoscopy is great for varices, but nobody really wants to swallow a big camera scope. It's very, very difficult. So they have these new pill cameras, which I thought were kind of cool, but they're not really useful in the acute setting. But if given the choice of getting a pill or an endoscopy, I would probably choose the pill. You guys know I love ultrasound, so you can do ultrasound for a couple different things here. You can look at flow rates through the varices, which will be helpful. It's done transabdominally. You can do endoscopy and get color flow Doppler to get a better idea. And you can see how your treatment's doing. People who are post-tips, you can look at flow rates and see how well they're doing with their treatment. And then of course CT and MRI will also tell you a little bit about how big the vessels are, how big the varices are. Risk stratification, look at your variceal size. If you get a flow rate over 20 cc's per second, that's really, really bad. There's a huge amount of blood going through there. There's a larger chance of them rupturing, and if you do rupture, the chance of them stopping bleeding is much slower. All right? People who have active alcohol intake despite having varices are obviously going to do much worse. And I found this red whale marks, which just looks like corduroy. If your whole entire lower esophagus is filled with varices, you're going to do much worse. Platelet count to spleen size, again, another ultrasound measurement, you guys love that. I don't know why the number 909 is what number they used, who knows, but it's all done by computers. But if you have a number of less than 909, it's much, much worse. You can see that for a lower number, you want a smaller number on top and a bigger number on the bottom. So if you have lower platelets, you're going to do worse, no kidding. And if your spleen size is bigger, that means your liver pressures are higher, so your spleen gets bigger. Kind of makes sense also. Right? If your pressure gradient is greater than 20, also a much worse outcome. You're going to do much worse. Treatment, well, if they're not, yeah.
Sorry, so you mentioned that the varices are more likely to rupture as the pressure gets higher in them. That makes sense. So is there a bimodal distribution as far as the time of onset of ascites? So like if you have really acute ascites and the pressures really spike up, you rupture, and then if you've had ascites for a really long time and they dilate a lot, then they rupture. But in the middle, like say I've had cirrhosis for a year, but not 5 years.
I'm not sure the answer to that. I've never read that before. I think it's just based on variceal size and flow through them. So if they get dilated very fast, they get to a certain size. But I've never seen anything about that bimodal distribution. It would make sense, and it's kind of, if you think about it, you can say it, but I've never read it before. I can't say it's true or not.
So like how long they've had cirrhotic ascites doesn't matter really?
I don't think so. One of the biggest problems is that people with disease don't always live for that long, so it kind of brings them more to the lower side. So, but I can't say. I've never read that before. I can't say.
And they can all tell you exactly when it started.
No, I mean, most of them have been drinking since age, like, 20 or whatever. So it's really hard to tell. So treatment, beta blockers, especially the non-selective beta blockers. This will decrease the contractility of your heart, similar to like dissections where you want to decrease the outflow from your heart. The less shear forces there are, the less chance you have of rupturing. Splanchnic vaginal constriction, if you want to cut down on the amount of blood getting into the liver, somatostatin works for that. Nitrates will dilate you up, and then behavior modification, stopping drinking is probably the best one for people who are not yet bleeding. I do want to point out that no drug is FDA indicated for this, so these are all off-label uses. Probably because all the drugs are old and there's no money to make in them, so nobody wants to study them. If they're bleeding, and they're bleeding a lot, you want to manage their airway. Don't let them aspirate the blood, because then they won't have lungs or liver. At least you can keep the blood down in the stomach, and their lungs will stay good. IV normal saline, get them tanked up, get the pressures up a little bit, but don't go crazy. You don't want them to be hypertensive, that causes more bleeding. Type and cross them for at least 6 units. Right? These guys require a ton of blood, because they're going to be losing it quite fast. FFP and vitamin K, you want to reverse their coagulopathy. Since they're not making the products anymore, you want to give it back to them. You want to drop an NG tube down if you can, just to get some of the blood out of the stomach. If they're vomiting, if they have a risk of aspirating, if they're not intubated. A lot of people don't like putting NG tubes down because there's a risk that you're going to break the varices as you put the tube through. I don't think I've ever seen any study and any literature to support that, but most of us don't like to put them down if we can get away with it. Medications we'll talk about. Endoscopy is really going to be the only cure for variceal bleeding. If you can get GI to come in, awesome. If you can't, you're stuck doing everything else. Balloon tamponade, we'll talk about a little bit more. And then surgery if you can't control it, and portal pressure reductions. All right, endoscopy is supposed to be done within 12 hours of GI bleeds. Just for you guys to remember when you're calling GI consults, you might want to remind them of these facts. Good luck. So somatostatin works pretty good. It decreases portal blood flow. It causes vasoconstriction. But somatostatin is a very short-acting drug, right? So they'll probably need a drip. So 1 to 3 minute half-life. Octreotide lasts much longer and is a little bit easier to use, much easier to dose. Vasopressin is great. It has the ADH effects, plus it's a suppressor, plus it stops portal pressure, plus it activates your platelets. So it gives you a lot of bang for the buck when you use it. Telepressin is a new synthetic that's only found in Europe. It's a vasopressin analog and has much longer vasoactive activity. Endoscopy, we talked a little about this in Steve's lecture. Sclerotherapy, you want to stop the varices from flowing and stop them from bleeding. So you can inject stuff inside them, like sodium tetradencyl sulfate. Ligation by banding is probably the most effective one that I've seen. They have less rebleeding compared to sclerotherapy. And then I noticed recently variceal obturation, which I thought was kind of cool. They can put tissue adhesives over it and try and stop the bleeding, but it's sort of hard to do. 5 to 10% of these were going to fail and are going to require surgery to fix the problems. Remember when you're doing your endoscopy, always look back where the scope came in, because this is what you're going to see, these big, fat, plump bleeders. So when you're banding somebody, what you want to do is you want to put a rubber band or a metal clip around the base of the varice. I thought it was kind of cool how they do it actually. What they do is just take a scope and they put a rubber band around the scope. And then they turn on the suction and they suck the varice into the scope. And then they just hit the button that opens up the tip and the rubber band just slides off and goes around the bottom. I thought it was kind of easy, kind of ingenious. The person who invented this is making millions of dollars. Why couldn't I think of that? Sclerosing therapy, what they want to do is inject stuff that's going to stop them from flowing, stop them from bleeding. I have seen a lot of cases, or not a lot, but a number of cases where there's a lot of complications. Some people are injecting like different cements and stuff that can actually embolize away, end up in your lungs and end up other places. A lot of complications. Chest pain is a big one, fever because you have not an allergic reaction, but a reaction to the stuff they inject. You can get pleural effusions because you're changing how the blood flows. Strictures, if they get smaller and they get scarred, and then more bleeding, worse bleeding, and then perforation if you're very, very unlucky. The sense-taking Blakemore tube, not many people in here have used them. I only know of a couple that have ever been deployed. Most of the time it's a last-ditch effort to stop the bleeding. They're really hard to get these tubes down. You put it down like an NG tube, but they're much more floppy and much more soft. So I would say that 100% of these people need to be intubated before you put the tube in. Intubate them, paralyze them, and then what I usually do is I'll put my whole hand in their mouth and I'll put 2 fingers into their esophagus and I'll use my 2 fingers to guide the tube down into their esophagus. They're really, really hard to get down. The Minnesota tube is very similar to the Blakemore tube, except it has a little port here. So any bleeding in the esophagus, you can actually suck out that blood and keep it from accumulating. Remember, there are 2 balloons in your Blakemore tube. We'll talk about those in a second. So when you put it down, you want to get it into the stomach, and you must take an x-ray before you blow anything up. Remember, this balloon at the bottom is a very big balloon. It's like the size of a softball. So if you were to blow that up in the esophagus where there are varices, you're probably going to kill them. That's probably going to be the last thing they ever do. So you want to make sure that you get radiographic evidence that the tube has crossed the diaphragm and it's in the stomach. So there are 2 balloons. Stomach balloon is done by volume and the esophageal balloon is done by pressure. So the first thing you want to do is put the tube down, get your x-ray, and then you're going to blow up your stomach balloon. And what it does is it makes a big fat softball shaped balloon inside the stomach. Once you have it blown up, then you want to put pressure on it and pull it backwards. And there's a couple different ways you can do that. We'll talk about that in a second. Once you have that pulled backwards, what it's doing is it's blocking blood flow from the stomach up into the esophagus. Remember, that's where the communication was between the liver and the systemic circulation. So you're blocking all that pressure from coming backwards out of the stomach. And then the last thing you'll do is you'll blow up the esophageal balloon, and that's done by pressure. You want to make sure that you blow it up last and you don't leave it up for too long. I always have to Google how much pressure to put in there. It's different depending on which tube you have, so you have to look it up by manufacturer. Just look online each time you do it. Sometimes it says it on the tube, but not always. I looked at it the other day, I forget which residents were with me, but it did not say on the tube what the volume and pressure were, so we had to Google it and look it up. Here's what these cases look like. They're just a bloody mess. Right? Blood's coming out of every single hole, every IV stick. Blood is just coming out of every place. So you have your Blakemore tube in. It's tied to a cling, which is pulling back up to the IV pole, and there's blood all over the bed. And if you can see, there's blood all over the floor too, because they're just oozing from every place. You can do it by counterweight, where you just put it over an IV pole and hang some fluid. Maybe a bag or 2 of IV fluid works. All right, he's close up, tying it around. There used to be a football helmet here in the ER some places, but I haven't seen it in probably 2 or 3 years. But you can also tie it around the football helmet or use a clamp and clip it to the football helmet as well, if you don't want to tie it up to something else. Surgery, they can go in and devascularize the esophagus, the last 5 centimeters plus the stomach. They staple gun it off and just take out the whole thing. Make sure you reverse the coagulopathy before you do these, and then these guys, the only other cure is liver transplant. If you can stabilize them and get them to advanced radiology, then maybe they have a chance of decreasing those portal pressures. Regular statal therapy fails 10-20% of the time, so 1 in 5 to 1 in 10. You may want to do embolization of the varices if you can get stuff in there, and then otherwise you may need tips. And tips is kind of cool. They go in through the jugular, and they put a hole going from the hepatic vein into the portal vein, and they just make a shunt going across. The problem with that is it lets blood coming out of the portal system into the systemic system, which has a lot of things in it that you really don't want in there. It's not been strained by the liver, so it often leads to change in mental status. Again, cephalopathy occurs in 20% of patients, and then a lot of these tips fail. 50% fail within 1 year. Now, is that due to the procedure not being done well, or is it just they have bad protoplasm? Hard to say, but just know that 50% of tips will fail within 1 year. All right, I appreciate your time. I know I spoke fast, but I had coffee this morning. Do you guys have any questions?